Okay, well, thank you so much for the introduction. I'm really excited to be here today with you all to discuss the role of nutrition in pregnancy for healthy babies and mothers. My name is Synneva Hagen-Lillevik. I am a registered dietitian and also have a PhD in nutrition and integrative physiology. I'm currently a postdoctoral fellow at the University of Colorado, Denver Anschutz Medical Center, studying gestational diabetes and nutrition. So I have nothing to disclose. I will mention that while I am working with Colorado, I do live in Idaho. And I will use the terms women, women, and mothers in this talk, as most of the individuals I refer to are female and identify as women. My objectives today are to introduce the importance of nutrition in fetal development and how it can impact future health outcomes for both the mother and her baby. To review the impact of macro and micronutrient intake in pregnancy on maternal and fetal health, to understand the normal metabolic changes of pregnancy and the impact of macronutrient intake on maternal metabolism, and then to discuss pregnancy and nutrition in the context of gestational diabetes and share some dietary data from a randomized controlled trial. I'd also like to bring clinical care and perhaps discuss how we might implement some of the ideas I present in our current systems of care. To set the stage for the connection of maternal nutrition and how it can impact the health of future generations is the story of a public health initiative that took place in Britain in the early 1900s. Officials were noticing that there were really high rates of infant mortality, and those that did survive were really malnourished and pretty sickly. Men who were screened for the military were found to be unfit for service. So in 1911, a midwife by the name of Ethel Burnside, and she's pictured here, was tasked to improve the infant mortality by training and sending teams of nurses to provide postnatal care, as well as birthing care to women all over the country. While they were doing this, they took really meticulous records of infants' birth weight, disease status, and growth throughout the first year of life. And these records were kept until about 1948. So then in the 1980s, an epidemiologist named David Barker learned of these birth records and wanted to study what happened to these infants 50 years later. He gained access really by chance to a very large set of records from the Hertfordshire district, as his sister was born in one of the villages. The senior archivist felt he would keep some of the nasty comments made by the nurses confidential. He then used the National Health Service's registry in Britain to track what happened to those infants that were included in the records and born before 1930. What he found was that birth weight, specifically those with very low birth weight and those that had slower postnatal growth or very low weight at 1 year of life, strongly predicted risk of death due to heart disease 50 years later. And thus, the developmental origins of disease, or the Barker hypothesis, was born, which states that the quality of fetal development, especially during pregnancy and the first year of life, can influence the risk of chronic disease later in life. So Barker's observations were based on birth weight and weight gain, and nutrition is one, if not the most important factor that shapes fetal growth and development during pregnancy. You can think of the in utero environment as an incubation medium for the fetus. The nutrients from the diet are critical in fertility, the development of the embryo, and also fetal programming. For example, vitamin A is important in cell division of the embryo. The growth and expansion of the placental tissues need energy and protein as building blocks. And also, I won't talk about this too much, but the actual gene expression of the fetus can be programmed or influenced by nutrition. And this is one of the hypotheses as to how the Barker hypothesis happens, is that different genes are expressed in the offspring depending on the in utero environment. I also want to make a case for optimizing maternal nutrition before, during, and after pregnancy for the health of the mother. Appropriate fetal growth can lead to less adverse birth outcomes. In addition, healthy maternal weight, weight gain, and pregnancy, and then weight retention in the postpartum period are associated with risks for future metabolic disease in the mother. For example, maternal undernutrition, which is more of a problem in developing countries but does happen here, can lead to small for gestational age infants, or SGA. SGA has been associated with higher infant death and also slowed growth in the first year of life. And infants whose nutrition essentially has been restricted may have micronutrient deficiencies in addition to the deficiency of overall energy. All of this is associated with adverse neurodevelopmental outcomes and chronic metabolic disease. In contrast, maternal overnutrition, which is generally what we see here, can lead to large for gestational age babies. LGA is associated also with higher infant death in addition to obstetric complications like perineal tears and C-sections. LGA infants often have kind of a catch down growth in the first year, which is not a normal or typical growth pattern. And LGA infants are also at a higher risk for childhood obesity and metabolic disease later in life. So this graph on the right is showing a U-shaped curve that both low birth weight and high birth weight are associated with the increased risk of metabolic disease later in life. So the goal is to optimize fetal growth with nutrition to reduce these risks. So a measurement of general maternal nutritional status is pre-pregnancy BMI and gestational weight gain. I do recognize that the use of BMI as a health status measure is controversial, and there's definitely stigma attached to BMI. However, in research and also clinical practice, while not perfect, it can be used as a starting point to help women have the best pregnancy outcomes, as pre-pregnancy BMI categories are associated with both maternal and fetal health outcomes. So women who have pre-pregnancy underweight BMIs are at a higher risk for SGA infants and also infants with slowed postnatal growth. Women with a higher pre-pregnancy BMI in the obesity categories, which is estimated about 30% of reproductive age women in the US, and that number is even higher when you add in overweight categories. These women are at increased risk for obstetric complications, including C-section. Also, infants born to mothers with a higher BMI are at risk for LGA, preterm birth, stillbirth, and fetal anomalies. So a potentially modulating factor of risk with pre-pregnancy BMI categories is gestational weight gain. Both low and excessive gestational weight gain are associated with adverse outcomes. For women with higher BMIs, the degree of existing obesity determines the impact of gestational weight gain on outcomes. For example, women with BMIs higher than 30 may have positive outcomes with very little gestational weight gain, but more severe outcomes with gestational weight gain over the recommendations. In 2009, the Institute of Medicine published guidelines for gestational weight gain for pre-pregnancy BMI categories, and these are used in clinical practice. As I mentioned before, there's evidence that even less weight gain for those in higher BMI categories may improve outcomes. Looking to nutrition, the estimated energy requirements for pregnant women really only increase in the second and third trimesters by about 340 to 450 calories per day, and that accounts for that accelerated fetal growth. Most women do not meet the gestational weight gain requirements, and with either too little or too much, but in the US, it seems that many have excess gestational weight gain. And nutrition is great because it is a potentially modifiable factor that can influence both pre-pregnancy BMI and gestational weight gain. And I kind of like the motto, eat better, not more, as we discussed gestational weight gain. So I want to give a brief overview of macro and micronutrients in metabolism and in pregnancy. So maternal macronutrient needs increase in pregnancy to support a growing placenta and also the fetus. especially towards the end of pregnancy. Macronutrients are carbohydrates, fats, and protein, and they all act together from food sources to give the body the building blocks and raw materials, as well as energy to support pregnancy. Pictured here are some sources of carbohydrates. Carbohydrates come in the form of sugars, starches, and fibers. The basic unit of a carbohydrate is glucose, which most of the body wants to use as energy. Glucose is stored in the liver and muscles in the form of glycogen. If too much glucose comes into the body, it can be converted to triglycerides in the liver and then stored for use later as fat. The body uses the hormone insulin, which I will talk about separately, to get glucose into the cells and keep blood glucose levels within a very tight range. The placenta itself has glucose needs as well as the fetal brain. Pictured here are some of the food sources of fat and protein, as well as the macro and micronutrient recommendations outside of pregnancy and in pregnancy. If you look under protein, you can see that needs increase in pregnancy from about 0.8 grams per kilo per day to 1.1 grams per kilo per day. Protein is made up of smaller molecules called amino acids. Amino acids provide the basic materials for building tissues. Some amino acids can be made in the body, but some need to be obtained from the diet, and these are called essential amino acids. Foods with protein provide high satiety as their digestion is slower and a little bit more complex than carbohydrates. And while it isn't easy, the body will convert excess dietary protein to fat and store it if the intake is high enough. So fat or lipids, there are different classifications of fats based on their fatty acid structure, which are unsaturated and saturated fats. In the blood, they are found in the form of free fatty acids, triglycerides, and cholesterols. Some fats are also considered essential as they need to be eaten through the diet. And if you look on the recommendation chart, these are listed as omega-3 fatty acids, and the needs during pregnancy are about 1.4 grams per day. Fats are also high satiety as they delay gastric emptying, and they need bile acids for digestion and absorption. So adipose tissue can take up and store free fatty acids from the blood. So I wanted to say a brief note about insulin. Insulin is a hormone secreted from the pancreas when it senses the body is in a fed state. So pictured here, when insulin binds to the receptor, I don't know if I have a cursor, but maybe you can see that here, the insulin receptor here. It tells the cell to take up nutrients from the blood, including glucose, amino acids, and fat for energy and growth. Most cells have insulin receptors. Also, the binding of the insulin receptor of insulin to adipose cells causes increased activity of another enzyme called lipoprotein lipase, which is pictured here. And which is how, with that enzyme, fatty acids are released from chylomicrons and taken up into the cell for energy and storage. Also, the stimulation of muscle cells can cause glucose to be taken up for energy without the use of insulin, which is one of the reasons a short walk is recommended after a meal to help with blood sugar regulation. So for today, I won't belabor all the roles of micronutrients in pregnancy. However, my takeaway is that micronutrients are very important, and consuming a nutrient-rich dietary pattern is one way to avoid deficiencies. So similar to macronutrients, some micronutrient needs increase in pregnancy. Some examples are listed in the chart on the left. And then also, I've just listed some of the key micronutrients here. And I'll highlight a couple of the ones that I think they get forgotten sometimes. So iodine is important for not only thyroid health, but also brain development and neurogenesis for the fetus. Choline and also DHA, which is an essential fat, are key players in both brain development and neurogenesis as well. Micronutrient deficiencies have been studied in pregnancy related to infant outcomes. Deficiencies in folate or folic acid are most well known for neural tube defects. Iron deficiency can lead to anemia, low birth weight, and neurodevelopmental outcomes. And deficiencies in calcium are associated with preterm birth and preeclampsia, and again, iodine deficiency with poor neurodevelopmental outcomes. So unfortunately, micronutrient deficiencies are common. In high-income countries, it's estimated to be about 15% of pregnancies, and this statistic can go up to even 50% in less wealthy areas. So it's very difficult to meet micronutrient recommendations through diet alone, so a multivitamin supplement containing key micronutrients is recommended. And pictured here are examples of nutrient-dense food sources. Whole grains, rice, beans, potatoes have carbohydrates, fiber. They're rich in B vitamins and protein. Seafood is is recommended in the diet once per week in pregnancy. And fish are a great source of unsaturated and saturated fats, essential fatty acids, protein, vitamin D, zinc, iodine, and other minerals. And then, of course, the rainbow of fruits and vegetables are great sources of vitamins and minerals, fiber, unsaturated fats, and protein. They also contain plant compounds called phytonutrients that can have big impacts on overall health, specifically cardiovascular disease. So I want to illustrate that dietary patterns can have positive impacts on health, especially during pregnancy. Many women in the US do not meet the recommendations for BMI and nutrition intake. This is characterized by overnutrition of foods with high calories that are not very micronutrient dense. However, I will say there's not one ideal diet for every person or every pregnancy. Taking kind of the common ground approach to diet, which means looking at overall dietary patterns, has been an effective way to improve health in a variety of settings. So healthy dietary patterns are also culturally adaptable. For example, if you can see in the figure there, different regions of the world have significant overlap in typical foods that are eaten that are nutrient-dense sources of carbohydrates. Diets that are restrictive in nature in pregnancy should be avoided, and I can discuss some of the reasons for that when we talk about the physiology of pregnancy. So, what are the metabolic adaptations of pregnancy? When growing a fetus, the concept of the maternal placental gradient is important to understand. So, glucose is the preferred source of energy for both the placenta and the fetus. Essentially, the maternal levels of blood glucose need to be higher so glucose can pass to the placenta and the fetus through facilitated diffusion. The Institute of Medicine recommends that women consume at least 175 grams of carbohydrate per day to maintain this gradient and also to account for maternal and fetal brain glucose needs. However, this recommendation was made before it was known the placenta also has glucose needs, so carbohydrate needs might even be higher. Basically, there are three organisms that need energy: the mother, the placenta, and the fetus. So for the mother, the first and most of the second trimester is really anabolic, meaning the mother's body is taking up nutrients and storing them as fat on her body for later use. The second and third trimesters are characterized by a reduced insulin sensitivity and increased insulin resistance. So on the figure on the left, normal insulin signaling is shown, and then what insulin resistance looks like is on the right. So over here. Basically, when cells become insulin resistant, insulin can bind to its receptor, but the cell doesn't respond by taking up glucose or other nutrients. The cell also gets a message when there's insulin resistance to start breaking down stored fatty acids and release them into the blood for energy. This leads to increased fatty acids, triglycerides, and also postprandial or post-meal glucose levels in the mother's circulation. So the physiological benefit of this is that the mother can then use ketones from fat metabolism as an energy source. So glucose is saved and shunted to the fetus. The data on ketones in pregnancy is limited, but there is evidence that very high levels of ketones may be harmful to the fetal brain. So I think the takeaway here is that energy balance is important to keep ketones within those physiological levels of later pregnancy. So these metabolic changes are influenced by placental hormones such as placental lactogen. So to illustrate this, I'll use a model of pre-existing insulin resistance and borderline metabolic syndrome as an example of how these normal metabolic adaptations of pregnancy can go awry. So often women enter pregnancy with pre-existing overweight and obesity, features of metabolic syndrome, and poor nutritional patterns. When the normal insulin resistance of pregnancy develops in the late second and third trimesters, the placenta is exposed to excess nutrients that are metabolized and then transported to the fetus. Importantly, high maternal glucose and amino acids promote fetal hyperinsulinemia, which drives the fetal fat accrual. So high free fatty acid exposure may also promote increased fetal fat mass. And so the combination of maternal overnutrition as a function of pre and pregnancy insulin resistance with poor lifestyle, fetal placental exposure to these excess nutrients, and the fetal hyperinsulinemia drives increased fat mass at birth, which increases the child's risk for childhood obesity and metabolic syndrome. So gestational diabetes, or GDM, as I'll refer to it, is essentially carbohydrate intolerance first identified in pregnancy. It's diagnosed by a glucose tolerance test at about 24 to 28 weeks gestation. Universal screening for GDM was adopted to clinical care in 2014, and it's the most common complication of pregnancy, and the prevalence is increasing globally. There are several adverse perinatal outcomes if not treated, and those are listed here. And some of the risk factors for developing GDM are high rates of gestational weight gain, family history of diabetes, ancestry, and nutrition. In addition, 50% of GDM can be explained by overweight or obesity. Something that I'm really interested in is the high risk of developing future type 2 diabetes in the mother. And this 7-fold risk is highest in the first 3 to 6 years postpartum. So medical nutrition therapy or dietary intervention is the first-line treatment, and about a third of women will need insulin or other medications to support blood glucose. The historical focus of diet for GDM was developed from guidelines for type 1 diabetes, and thus a restriction of carbohydrates to 40% of energy with higher fat was recommended, with ultimately the goal of decreasing the postprandial glucose levels. However, now there's quite a bit of debate about the diet for GDM, and evidence is mixed for a variety of dietary patterns, prompting the idea that different approaches might show positive outcomes. So a GDM diagnosis is more than just tight maintenance of blood glucose with diet. So for many, up until diagnosis, pregnancy was normal. And then suddenly it is now high risk with a diet to follow, more monitoring, serious consequences if ignored. This creates really an opportunity for anxiety, fear, and depression. There are psychosocial impacts with the diet prescription and a focus on restricting carbohydrates. Starting a diet late in pregnancy is challenging, plus restricting carbohydrates can put stigma on cultural foods or dietary patterns. Thus, an unintended consequence around this fear and anxiety can lead women to freely consume dietary fat, often saturated fat, to feel full and a safe way to eat in pregnancy. This dietary behavior of increasing fat can actually worsen the insulin resistance in late pregnancy, kind of exacerbating some of these problems. So this isn't a review for dieting GDM, but the question of can nutrition therapy for GDM address metabolism, mental health, and family wellness as medicine be possible? So essentially, nutrition for GDM could be nutrition for all pregnancy and postpartum eating patterns. To test this hypothesis, my research mentor, Dr. Hernandez, and her team performed a randomized control trial looking at the choice diet compared to the low-carb conventional dietary pattern in GDM. So choice stands for choosing healthy options in carbohydrate energy. And it's essentially a nutrition pattern designed for GDM that focuses on increased dietary quality. It was developed under the principles of mothers having flexibility in their carbohydrate intake and to reduce the restrictive mindset. Importantly, it was in the context of appropriate calories and limited simple sugars. So on choice diet, 60% of total calories came from carbohydrates, whereas 40% in the conventional low-carb diet. Also of note, in the conventional diet, 45% of the energy came from fat. So it was a little bit higher diet, a higher fat diet. Protein was the same in both diets. At the end of the study, those on choice had about 300 grams carbohydrate per day versus 200 grams in the low-carb conventional diet. So both diets had all meals and about 80, which was about 80% of calories provided. So that was kind of a unique feature of this study. For 7 weeks, all the food was provided to the participants. The diets were designed individually for participants to not gain weight, as most had achieved higher than recommended gestational weight gain at the time of the study. Simple sugars were provided and fixed at 70 grams per day. The carbohydrates were complex with low to moderate glycemic indices, and fiber was also similar at 24 grams per day and 29 in choice. So I like to show this graphic of an example lunch in this study with the conventional diet on the top and the choice diet on the bottom. As you can see, they're both quite similar, just some small differences in the grapes and nuts for carbs and fat, and chips versus salad for the fat and also carbohydrates. Also of note is the light versus regular mayo. And really the point here is that these small changes alter the dietary composition to fit within the macronutrient distributions for each study diet. And I also like to highlight that I feel like none of the food in this lunch is particularly exotic or unfamiliar to someone who is following a Western diet, but it also fits within healthy guidelines for pregnancy. So I'll just share 2 results of the study with you. The first was the primary outcome for the study, which was infant percent body fat, and this was measured at birth. So between the 2 groups, there were no significant difference in birth weight or body fat percentage in the infants. There was also no difference in cord blood insulin. So this graph shows blood glucose levels as measured by continuous glucose monitoring at the beginning of the study and then 7 weeks later. For the mothers, both groups had excellent time and range of blood glucose between 70 and 140 milligrams per deciliter. Both groups were also below the 1 and 2 hour postprandial glucose targets. Importantly, as the normal insulin resistance of pregnancy increased over time, both groups did not have increases in blood glucose. And so the takeaway here is that higher carbohydrate intake is possible in GDM with small daily changes to dietary pattern to have good outcomes and glycemic management within target ranges. So it begs to ask the question, could this approach decrease the psychological burden of women managing GDM with a more flexible approach? And can this dietary approach carry over into the postpartum? And is it sustainable for healthy mothers and families? So this was a lot of information, but how can we get some of these ideas into clinical practice? The expert recommendation is that it is imperative that healthcare providers have the time and means to provide educational support and to discuss optimal nutrition with women of reproductive age to improve their health. So anyone who is a clinician can tell you this is a tall order. Clinicians in a variety of settings have said they do not have time or training to address nutrition. So within a care system, ideally there'd be an interdisciplinary team and an interdisciplinary team with a dietitian and a mental health provider that can address nutrition and also some of the psychosocial issues that come with nutrition and pregnancy. However, this is often not the case and not possible. And part of my current research is to see how we can package these ideas so that clinicians can feel empowered and provide adequate information to their patients. So I'll leave you with a couple ideas and perhaps we can discuss more of what we can do. But with patients, really address the mindset and misconception that you can eat whatever you want in pregnancy. This idea seems to center on social acceptability of gaining weight in pregnancy and does not address dietary quality or appropriate gestational weight gain. If you can, gather a general sense of nutrition history and what they might be doing currently with their diet. Ask what a typical breakfast looks like or what they had for lunch yesterday, and then can provide suggestions of small changes to make towards improved nutrient quality within a culturally sensitive way. Implement small mutual goals with your patients that they can do daily with nutrition. Perhaps it's focused on higher quality carbohydrates or diversifying their fat intake. And finally, one can provide examples of nutrient-dense meals in a visual way to demonstrate what healthy types of foods could be. So to summarize, nutrition is a modifiable factor that shapes the in utero conditions to program the offspring for lifelong health or disease. The food a mother eats before and during pregnancy provides energy and building blocks for both a healthy mother and baby. Gestational diabetes is a disorder of metabolism in pregnancy and can be treated with diet. And there's a critical need for nutrition education and interventions before, during, and after pregnancy to ensure the best health outcomes for both mother and baby. I'd like to thank Dr. Terry Hernandez, my current research mentor, Dr. Ryoko Kozler for providing me the connection for this opportunity, and the ECHO team. And then also the Infant Gold research team who conducted the dietary studies for gestational diabetes, and then my fellowship with the University of Colorado. So thank you so much.
Thank you. Thank you so much, Synneva. Let's see if anyone has any questions. Nothing has come into the chat yet, but if anyone has questions, you can feel free to unmute or you can put those in the chat as well.
Should I stop sharing?
Go ahead.
Okay.
I'm not hearing anything. I am wondering though, if anyone's willing to kind of give their insights on this, but kind of those recommendations that Synneva gave at the end about incorporating this into your clinical practice. Does that seem feasible? What are maybe some of the barriers or difficulties that that may come across when you're bringing up nutrition or with your patients? If anyone's willing to share.
I'm Rachel Root, I'm a psychologist, and so I'm feel like I'm relatively removed from the side of things, but I really liked, I think a takeaway for me was, and I hope I got this right, but you said, eat better, not more. And I really liked that. I think it's just, I love these little like smart phrases, these quick, easy things that you can provide for people that can kind of stick with them. And I don't find myself often talking to my patients about their nutrition. I mean, it comes up obviously, right? As people are stressed about doing the right thing, right? Something that I got from Dr. Saib, I've heard him say many times is that, pregnant folks are a captive audience, right? So they want to be doing the right thing. They want to be making the right decisions. And obviously that causes a lot of stress, which is usually the part that I try to catch. for them. And so just those little things that I might be able to throw out there, since I can't like give these specific suggestions and potentially referrals for nutrition, but I like that little piece and I can imagine myself using them.
Thank you. Thank you so much, Rachel.
I think this is one of the hardest things that we do in a prenatal visit is the educational aspect of it. Just for reference, I'm Jennifer Cook. I'm a FM OB. And interestingly enough, I was late because I was doing an OB clinic this morning and saw a couple of patients. And this was the exact thing of, talking through them, identifying all the risk factors, and then both families asked at the end, like, what about nutrition? What should we not eat or other things? I was like, I've already been in this room for 60 minutes. Like, I cannot now spend another 30 minutes telling you about what you can eat. It was like, I'll refer you to dietitian. So I think that it is fairly difficult to incorporate that. And I think that's the beauty of what we have in following them through their pregnancies, that you can add those little bits as you go along. So next time you can choose that as an aspect of, okay, we talked about this briefly. I told you no raw meats, no unpasteurized things, don't touch your cats. Like, okay, next time we'll talk about a little bit more. Like, I'm going to give you three small things. Maybe I'm going to tell you the exercise is fine. I think very small takeaways. I've found over the years that patients have about a capacity of 3 items that they can retain. And then they're not going to remember anything else. So I try to give everything in slots of 3s to help them retain their information. And then handouts. We do have handouts that we provide in like a new OB bag that we give. That gives a little bit of brief about diet information and have them make sure that they look at it and come back and talk to me later. But yeah, it's hard. And I feel very deficient in my knowledge around this. A lot, like recommendations, what should we do, and how many carbs at each meal. And are you kidding me? Like, that's a lot to manage. I don't want to sit here and I just want to eat. I'm so hungry right now. Like, I don't want to count how many carbs are in here. So, I mean, you have to come to the level where your patients are too, of the realism of it.
Thank you so much. That was really great insight. Ryoko, I know you had kind of brought up, like, introduced us to Synneva. I don't know if you had anything else to add too.
Yeah, like she's amazing, like a speaker, about like very knowledgeable for the nutrition. It's always good to know as providing the care for the perinatal and the population to know the background how its micronutrient actually work. So it's a great differentiator to know. But Sunamadu, if you don't mind, could you share if any like resources we can kind of look it up and for when we providing the patient care? Do you have any recommended like resources that we could look it up?
Yeah, that is a good question. I know that there's some general like my plate for pregnancy that provides some kind of visuals. Uh, so I'm kind of in the gestational diabetes world, but so for general pregnancy, I don't know, I might need to get back to you on that. But I know that the My Plate for pregnancy at least has some pictures of foods and kind of shows like, okay, a balanced dietary approach at each meal. So,
Thank you. Yeah, and gestational diabetes is a very stressful, like as a perinatal, like a mental health and a part, it would add it up and a lot of anxiety and what they can eat and cannot. And yeah, I think it's like education piece is very important and alongside of the care. Thank you, Kim.
it looks like someone put a link in the chat for the
Mhm.
dietary supplements. Yeah, there. Yeah, it's right there. So those are, kind of just some basic starting points. There's a lot of information on the internet and, kind of wading through that, whether it's good information or not. And I think one way to navigate that is, anytime you're really restricting something. I guess the take home is that more of like just like a balanced energy and micronutrient intake in general is something that we can all strive for, and then especially in pregnancy. So.
Thank you. We got a few minutes left if anyone has additional questions or comments.
Oh,
I had a quick question, sorry.
No, go for it, please.
So I had a sister with a neural tube defect in her child, so they had some, folate deficiencies. So I was just wondering if there's any monitoring, I guess, that they can do prior to or early on in pregnancy that can help pinpoint those nutrition deficiencies to help promote, I guess, improved health in that fetus, or maybe even when people are planning to get pregnant, if they can check those things out, if there's things in that regard.
So there is a lab test. You can measure folate, but it doesn't really capture like sort of long-term folate status. It's kind of, what you've eaten kind of recently that's in the blood from my knowledge on that. And actually measuring, yeah, your B vitamins in that way, you have to do some kind of other clinical tests that are not standard. I think from kind of an epidemiology standpoint, just making sure that people are supplementing with that before pregnancy, and then also looking at dietary patterns. If they're eating carbohydrates that tend to have higher levels of folate and other B vitamins in there. So I don't know if anyone can speak more specifically to that, but that's my
So,
oh.
yeah, the neural tube closure happens at 6 weeks last menstrual period. I mean, that's basically, 4 weeks into after conception. So it's really early. So you're not going to be able to affect neural tube closure after the pregnancy. Most people are, not recognizing that. So what we recommend, of course, is especially if you have a history of a neural tube defect, is you start supplementing well before that. And most of the studies that were shown that folic acid decreases the rate of recurrence of neural tube defects involve taking 4 milligrams a day of folic acid. That's a really high dose, and probably less probably works also. But certainly that's, where I think we're doing a lot better. I think since, in the last 30 years or so, we've improved our fortification of foods with folic acid, which is better. Folic acid is one of those vitamins you can take a lot of because they're water soluble. So, you pee off the excess. It's not like vitamin A or the fat soluble vitamins that can make you sick. So, yeah, I think the biggest thing is just to try and, and I also recommend always, an extra milligram of folic acid in your preconceptional counseling.
Thank you. That's really good information. I was going to say that kind of speaks to the whole, before pregnancy, making sure that nutrition and supplementation and we've got some of these good things established, but of course that's not the reality for, I would say, many people. So, maybe optimizing the health of reproductive age women in general through nutrition or, yeah. Mm-hmm.
And before I became specialized in maternal fetal medicine as a general OBGYN, I recommend women in their reproductive years need a multivitamin with iron every day. I mean, the incidence of anemia in women with their menstrual losses, et cetera, is so high, not to mention the need to make sure we have adequate, keep up with folic acid and those other micronutrients as well. Because let's remember, most pregnancies are not planned.
Thank you. Thank you all for sharing this information and for answering that question. It was super helpful. And thank you, Jessica, for asking the question. Had some great discussion there. So because this is the last session, I am going to have our panelists all we're going to go around and they're each going to give us one pearl or just something they want you all to take away from this series, from this topic of maternal health care. And also just thank you for joining us especially if you've joined us, from the beginning. Thank you everyone for joining us in this series as well. Let's start with the way that we usually do our introductions. So I'll start with Jennifer and then we'll go with Stacy.
Sure, you put me on the spot. It's like, yeah. Stacy's wiping his brow right now because he's like, "Whew, I got like 5 minutes to figure out what to say."
Yeah, but if you take the easy ones, I'm gonna have a hard time,
I know.
So.
Okay, just one thing is fine, and we'll go through the rest of the panelists. Yeah.
No, I mean, I think for me, we've learned a lot in this series, which I think has been instrumental. Like I've learned a lot over the course of it. And I think for me, just remembering that pregnancy is a journey that we're going through with these patients, that we don't have to do everything at once, and that it's a pretty magical time of developing a really nice relationship that is going to set the stage for them, for their health going forward and for their family in terms of like being a captive audience and changing their changing the ways that they may proceed with their own health and their own lifestyle measures. So not to be afraid of pregnancy, but just enjoy the journey that you're on with these patients.
All right, you did sort of take mine, but that's okay. I mean, and I agree. And I think like Rachel brought up earlier, the fact that, it's a time that women are motivated in their lives and, looking forward to the whole, starting a new family or adding to their family, et cetera. And then I think the other thing that I guess I would add, just as a piece of advice, not necessarily what we learned here, is remember to meet patients where they're at. And it's not all going to be wins. I mean, that's the big thing I've learned in medicine over the years is, once in a while you have a huge win, but usually it's just chipping away and helping people in their lives.
Thank you. Those are great. I really appreciate that. Okay, let's move on to Rachel and then Ryoko.
Oh man, okay. I mean, as a perinatal mental health specialist, obviously that's kind of my angle. I just think it's important to remember, right, that perinatal mood and anxiety disorders are the #1 health complication of pregnancy and childbearing. So it's not to be discounted. It really is something that's so incredibly important for not only all of us who care for pregnant individuals and postpartum individuals, but that interface right with them and have them in our lives and are them, is that this is a very, very common complication, and it's one that requires a good amount of understanding and education. So continuing to educate yourself on what that looks like, how you might be able to help, and prevention methods, right? A lot of these things, there are so many prevention methods, particularly when it comes to things like birth traumas and re-traumatization. It's so preventable in many ways. Is that if we're continuing to educate ourselves, we're continuing to understand how to support these individuals in their mental health, and we can really prevent these problems from happening many of the times, not all of the time, but a good number. So I just encourage you to continue educating yourself on the mental health side of pregnancy and childbearing.
Okay, so all of above, and everybody's sharing all of, but one thing like I want to say, like we can change it through utilizing the normalizing and the non-stigmatizing language. The stigma is huge, but we can support and from our side and to using the language and non being the providing the reducing the shame and reducing the shame for why we are talking about the mental health and all the other problems. So that's the one thing we could carry on to our care.
Okay, thank you. Parker, and then I'll close this out.
I think for me, it's kind of an amazing time to be here, just with all the things that have changed, with all the new information. I mean, it wasn't that long ago that we really didn't have a lot of studies on with meds and pregnancy and things like that. It feels like we're in a place now where there's multiple resources. There's apps, there's things that make it really easy for us to stay up on top of things. So I just encourage people to find one that they like and make sure that they stay up on it because things are changing. So it's a great time to have that information.
Okay, thank you so much. And I appreciate our panelists, our staff, and all of our participants who have been able to join us.